Welcome to an AOT for Allegheny County webinar. I'm your host, Ruth Johnston. I'm a writer and mother who lives in northern Allegheny County. Treating severe brain illness isn't a fun topic, but it's my topic because more than 10 years ago, my oldest son developed paranoid schizophrenia on top of high-functioning autism. There were legal barriers to getting him treatment, and so we were not able to prevent a tragedy that came from his illness. Pennsylvania law let us down twice. First, when it would not let us force him into treatment against his choice. And second, when it then sent him to prison for 20 years. If you want to read about what happened in my family, you can go to www.aotforalleghenycounty.com. And I tell the story there, and there's more information. Pennsylvania law now allows an option for a civil court order to mandate medical treatment. But because every county has to design a program and opt in on the law, at this time, there's no county that offers this option. I want Allegheny County to be the first to help families find treatment before tragedy by opting in on the law as soon as possible. My guest will be Andrea Kepler, the head of health services in Dauphin County, Harrisburg, our state capital. This is because, in addition to her experience in leading a lot of other health services, she also went and worked in an AOT program in New York City. And I want to ask her questions about what it was like day to day. Try to pull it out of the theoretical and imagine if we had a program like this, what kinds of things would a team encounter? She'll be joining us by and by. And in the meantime, I'm just going to start talking about what AOT is and why we need it. A lot of people aren't aware of the answer to either of those questions. AOT stands for Assisted Outpatient Treatment. Obviously, it's an outpatient treatment, not inpatient. But the assisted part is the part that makes it both helpful and controversial. With many things, you don't have to assist somebody to get help. People who are sick with cancer usually seek help. In a situation like, a car accident on the roadside, all we have to do is bring help to them on wheels. The ambulance arrives and the people want to get help. But what happens if they're not able to get up and walk to the ambulance? Nobody just stands there by the door and says, okay, everybody coming? And then they don't turn to each other and say, they're not coming. I guess they don't want help. Because we understand that in that case, the person may be unconscious or wounded in some way that they can't walk. And so we bring a stretcher and we put them on the stretcher and we carry them and we put them into the van and we take them to the hospital. That's essentially what assisted outpatient treatment is doing, except because it's aimed at a brain illness, the help has to be very different. The stretcher has to come in the form of a civil court order. The problem with a mental illness, a brain illness, is that it is compromising the one part that can tell somebody how to make an informed decision about their treatment. If you have diabetes and for some reason you choose not to treat your diabetes, it's presumed that as an adult, you can listen to the risks, you can listen to the treatment options, and you can make that choice. They can try to persuade you. If you're just, some unsociable old codger up on the mountain and you say, never mind, I'm not going to do it, you have that right because you were able to understand the risks. When somebody has a brain illness, they really can't understand those things. We see this in some cases. Probably what people are most familiar with and run into the most will be something like dementia or stroke. Some people with dementia are aware that something is wrong. Others aren't. And they'll tell you that you're the problem. I'm fine. You just keep talking in a confusing way that I can't follow. Stop it. And there's a well-known syndrome when certain types of strokes leave somebody paralyzed on one side, but the part of the brain that got paralyzed, that had the stroke damage, is also the part that would be able to look around and notice something's wrong. And it's been damaged, and so they can't tell. So maybe for a couple of days or even up to a week, you have a person in the hospital, they're paralyzed on one side, and if you ask them, are you paralyzed? They'll say no. And when a doctor says, okay, then reach out and take this with your left hand, holds a pen out. They'll just say, oh, I don't feel like it. Well, it's because you can't move your hand. Oh, I can move my hand. I just don't want to right now. Just not going to do it. And they'll go on like that for a while. Eventually they learn. Another thing where we're somewhat used to it is when you have, hi, Andrea. I was just giving a general, are you there? Can
Yes.
you hear me?
Can you hear me?
I can. I
Right.
was just giving a general introduction to the idea of why brain illnesses need extra help. And I'll just wrap up my thought and then introduce you and we can jump into that.
Okay.
I was just going over the fact that we're used to seeing that with dementia, sometimes with stroke, or with young girls who have anorexia nervosa, and they can be starving to death, but they apparently really do look at themselves and think they're fat. Something in what's going wrong in their brain blocks them from being able to see that they're starving to death. And so the same kind of thing happens with paranoid schizophrenia and sometimes with severe bipolar disorder, where the part of the brain that be able to tell that they're talking funny, doing weird things, not understanding people, running into danger, that part is just damaged and they really can't tell. And so it's a different question. You know, with a car accident, with an ambulance, you get a stretcher, but with a brain thing, you need a stretcher for the brain. And that's just going to be a little bit different. So assisted outpatient treatment is a legal structure that permits a civil court to look at the evidence, look at evidence that somebody is really deteriorating and is going to keep deteriorating, and put them under a civil court order mandating they have to work with a team. In a sense, part of the trade-off is that with them losing a little bit of their civil rights, that is the right to refuse treatment, on the other side, then we create a lot of guardrails around that, having a team with more than one person, court oversight, um, legal evidence required, and things like that to try to make it so that, you know, we wouldn't make a mistake. And, you know, a lot of people are, have you noticed, a lot of people are worried about mandating treatment for somebody because they, they think that they put themselves in that position and they say, well, you know, when I was going through my divorce, my ex told everybody I was crazy, and things like that. And we have to understand that in a case like that, if a whole team was talking to you and if evidence had to be presented to a court, you know, your angry ex wouldn't have been able to pull that off.
There
Um,
are a lot of protections written into the Pennsylvania law to
a
assure
lot,
that an examination by an
right?
appropriate individual, a qualified individual, is
Mm-hmm,
conducted and then conducted with regularity to assure that the person continues to meet the criteria as
right.
designated by the law. And that examination must be presented to the mental health review team.
Mm-hmm,
In essence, the judge or the appointed MHRO, who is appointed by the judge to review all that information. And it also
mm-hmm,
must be accompanied by a recommended treatment plan that must be approved by the
mm-hmm,
court.
mm-hmm.
So there are really a lot of
A lot of,
protections that are built into the
that's right.
Pennsylvania law. But granted, no one likes to be told they must do
No.
something, and we have to acknowledge the seriousness of that.
Mhm.
So when we get to the point of even considering AOT, it really is a statement that we've tried everything and we need to try everything and exhaust all other
Mhm.
opportunities before getting to this point. And that should never be taken lightly.
Yeah. Um, just I want to talk about this more, but let's real quick introduce who you are and why we're talking. You're the Director of Health Services in Dauphin County.
Well, technically, my title is Administrator of Dauphin County Mental Health, Autism, and Developmental Programs. And I
Okay,
have been in this position since September of 2020.
okay, okay. Um, and but the reason we're talking and is that in your career, you took an unusual detour. As I understand it, you were CEO of one of the state hospitals. And I would think that the normal career path from that would be, I don't know, maybe you start working for the state or something. And instead, you made the unusual decision to go to another state and and work in an assisted outpatient program.
Well,
And
first,
that's
I
what I
want to
really want to
dispel
talk about.
any notion that um I took this abrupt turn.
Well, that
I had actually
looks
worked
to
in the
me.
state hospital system for 37 and a half years. And
Mhm,
so when I became CEO, I never did so with the idea that I would be there for a prolonged period of time. And so by the time I got to 10 years, it was working on me that it was time to really
mhm.
turn the things over to someone else, because I didn't want to be that kind of an administrator that moved in and didn't know when to leave. so, and I am a native New Yorker, so that
Okay,
may provide some perspective on,
okay.
because for some people, the idea of going to do the kind of work that I chose to do in New York City, that was really abrupt, and it was not so abrupt for me. But I really still had a very strong passion
Mhm,
to work for people and support people in their
mhm,
recovery. And that's in a roundabout way what led to me thinking, oh, well, maybe I should look in the city, because their
mhm.
population is so huge and their issues are
Oh,
so huge. Most certainly, my passion level can find something that would appeal to me. But what
yeah.
I ended up with was nothing that I started out thinking I would want to do, and that is to do street homeless outreach services for adults with serious mental illness and substance use disorder. So I left the state hospital system as a CEO, and I went to work really working on the streets with people who were not permanently housed. And while I had thought I had learned a lot in the state hospital system, I can honestly say I learned a tremendous amount working as I was the clinical supervisor for a
Mhm.
homeless street outreach team in the Bronx. Um, and
That's
that was not my
that's hardcore
background,
as it
coming from New
gets.
York.
Yeah, that's
The Bronx was not, I was not a native of Bronx, so that was all new for me. Yeah.
what I'm sorry, what part of New York were you from again?
I'm originally from Queens.
Oh,
Um,
okay.
so
I lived in upstate New York for much of my adult life. So from my upstate perspective, Queens and the Bronx are really the same thing. So I'm just laughing.
But
So,
what I came to appreciate is that every person who is unhoused and meets the federal definition for chronically homeless,
mhm,
that they all have their own very personal story for what happened in their lives, and how that became their outcome. And I really became very enamored, so to speak, with every person's personal story, and that became a bit of my aim, just to learn as much as I
oh,
possibly could about the people that we were supporting. And
mhm,
I would credit that as a prime key ingredient when we talk about engaging people in services. I
mhm,
mean, if you start with, the conversation of selling a service that people are really not interested in, that's probably not
mhm.
a good approach to engaging people. And so we didn't do that. We took a different approach, a different tactic. But in a roundabout way, that's how I ended up coming into doing the work that I did in New York, that I very much enjoyed.
So when you were heading up an AOT team, that was working with the homeless population specifically, or was that started with the
I
homeless
headed
and
up a
shifted?
homeless outreach team and the clinical component of it. We, as a clinical supervisor, I had what we called 958 authority under New York State law that
Mhm,
gave me because I completed designated training through the state level Office of Mental Health. Um, that gave me the ability to complete an examination in the field and call upon police to pick up an individual to take them in for examination against their best wishes. So that was my authority and that was my responsibility. Should we come upon a person who met that designated criteria for involuntary examination and could be the starting point for AOT consideration. My team at any one point in time tracked about 240 individuals throughout the borough of the Bronx. So we were quite busy, and we had a team that went out 24/7 at all hours of the day in the cold weather to ensure that if the temperature went below a certain amount, that they knew there were warming centers, that we asked them to go into a warming center. We always made sure that people had water and food. During the hot weather months, we always made sure that they had access to cooling centers, because that's what really taking care of people is all about. So that was our first and foremost concern, basic health and safety. And then beyond that, doing the work that was necessary to engage them in an effort to engage them in mental health related treatment services. And certainly we worked with 240 people. A certain percentage of that population had serious mental illness. Some had serious mental illness as well as substance use disorder. And
would you say probably maybe half of them, or was it higher than that?
Oh, it was probably close to all that we worked with.
Yeah.
It really was close to everyone that we worked with. Some more seriously disabled, quite honestly, than others. Some in greater need than others. And they, of course, tended to have the bulk of our attentions. And so we would get creative every day in looking at, okay, how can we better engage people as a very first step? We never talked about forcing treatment on anyone as a first step. We always wanted to give everyone the benefit of the doubt and talk with them about the potential benefits of coming in to talk to a psychiatrist or a physician about medical issues. And that often was when we had success with getting people to come in when they were having pain or some kind of medical issue, and they started questioning whether or not they should receive services. There was one man in particular that we were successful in getting him to come off the street, and it was because he had a foot infection that turned out to be osteomyelitis. So, but it was his pain that motivated him to do something different. He had been on the streets for 25 years. He was really very comfortable with that lifestyle. He wasn't looking to make any changes, but having so much physical pain really motivated him to see what else he could do.
So in a case like that, did he go on then to get psychiatric treatment? Did he,
He did, actually, that particular man, he came in and we were able to accommodate him in what we call a stabilization bed, which was really in a rooming house type of atmosphere that my company contracted for, a temporary safe place for a person to stay until we could get them connected to permanent housing. So he did stay in the stabilization bed until we were able to secure permanent housing for him. And during that time, he was amenable to receiving both physical health as well as mental health services. And he really just continued to recover and progress. It was really wonderful to witness that. It really was. And to think that he had been living on the streets for 25 years, and that was the first time in 25 years that he started feeling better. And I remember asking him if he might want to get in contact with his children. And his response to that was, no, not yet. He really wanted to secure housing before he reached out to them. And I think for him, that was his way of saying, I want to feel like I have some good news to share with them before I do that. So that individual, we never had to consider any kind of involuntary process because once he started back on the psychiatric medications and we assured that he received his medication refills and he was taking them as prescribed, he just continued to recover is what happened. And his brain continued to function better.
that's really what everybody would like best. I know people
Sure.
who oppose assisted outpatient treatment really have a view that if you just present people with things, show you care, ask them how their needs can be met, you can
Mhm.
draw them in. And so clearly sometimes that works.
Yeah. And
And it's
sometimes it doesn't. And there was a young
well,
man that every single member of our team just really adored this gentleman. And he had a very elaborate encampment in a very residential neighborhood. And he thought his mission was to teach the young kids, like young adults and adolescents. And so he'd be very strategic in selecting his location, because he always wanted it to be in a neighborhood where there was a park, because he realized that's where he could access the youth. He would see them, and
that
he
can't
would
have
talk
gone
to
over
them.
well with the
Well,
parents.
no, and ultimately that's what happened. And so, as the neighborhood parents and just the general neighborhood got keen to what was happening there, and increased their outreach engagement of local law enforcement, and the scrutiny started intensifying on this gentleman, he started really stressing out. You could almost see him breaking down psychiatrically. We were not effective with engaging him to get into treatment, even though our psychiatrist even went out and spoke to him for hours at a time on the street corner. He would be very receptive to any and all conversations. That was never a problem to get him involved in conversation, but he was not interested in engaging in treatment.
Yeah.
So but when the neighborhood started really getting keenly aware of his presence and what he thought his mission was in the neighborhood, that's when things started really going downhill. And then he started with another strategy. He'd go into the library. And one day he lit a candle in the library, and he felt that was part of his meditational practice. And, he was immediately
Yeah.
told he had to stop that, and he didn't want to stop that. So that led to a police intervention. I think that was probably the first time he was involuntarily committed.
Mm-hmm.
Um, but he didn't stay very long. He was evaluated. He agreed to some medication while he was in the hospital, but then he was discharged, and he chose to return to his
No,
location on the street. So things again went back to their same pattern, where
yeah,
now the library and the local neighbors, were on
right.
to him, and he was really feeling the stress and the pressure. And he went into a local pizza shop that had befriended him for some period of time, and typically would give him the leftover pizza that was
Uh-huh.
there at the end of the day.
Uh-huh.
And a law enforcement officer came into the restaurant, and he had a very sharp reaction to the law enforcement officer after having been involuntarily committed. And
Uh-huh.
that led to a scuffle with the law enforcement officer and a second readmission. It was at that point that we then started seriously talking about AOT.
Okay.
Now, it's important to understand that there are some commonalities with Pennsylvania law and some
And
differences
some
from
differences.
Pennsylvania law.
Yeah.
Like Pennsylvania, New York State AOT law has no real role for the judiciary, other than, as with current commitment procedures, the judge must order the person into treatment, and
Mm-hmm.
then any renewals must be ordered by the judge. But
Mm-hmm.
there's no ongoing role
Mm-hmm.
for the judiciary in AOT in New York State,
I
much
think I
like
think
in Pennsylvania.
yeah, I think I read in with Pennsylvania's law that at a 6 month point, 180 days, they would want a judicial review and then it could be renewed.
Correct. But in
You know,
other
yeah.
states, and this is what's confusing for some people,
Mm-hmm.
in other states, the judge participates on a regular basis in
Yeah.
team meetings and so forth and so on.
Yeah.
Our law does not require that, and neither does New York State. New York
Okay.
State, the responsibility for AOT is with their state office. Um, And then they in turn delegate to local offices that are in each borough or each county. So that's a distinction from Pennsylvania law. Although in Pennsylvania law, I guess the similarity would be that the county MHMR administrator would have oversight for implementing AOT. So differences, commonalities. In hindsight, I would say we're probably more similar than not. And what we ended up needing to do for this gentleman, going back to my gentleman in the neighborhood, who's now in his second psychiatric admission, we started talking to the inpatient treatment team about what we call a step down, meaning that we asked the inpatient treatment team if they would complete a petition requesting a period of AOT that would be commensurate with the person's discharge date. They agreed, and that led to a hearing. We developed a treatment plan. These are all multiple different steps in the process. And there was an AOT order for our person to participate in outpatient treatment. And I would say that AOT order in that gentleman's situation was very, very effective with promoting his understanding that it was expected that he would go to a monthly appointment for an injectable medication. That was the other piece that we talked to the inpatient treatment team about, the benefit of an injectable medication. So they started that all during the hospitalization, and he got on the injectable, and he reluctantly initially followed up with the first appointment, and then it really became a hardship to get him to cooperate. But we never all that time stopped trying to get him to go. So we didn't get him to show up on a timely basis, but we would eventually get him to show up. And we more or less, looking back on it, as I realize it, we were effective in him getting his monthly injectable medication. So he started recovering, and we saw a demonstration of better problem solving, better judgment, particularly given that he was still at his street location. And then we got him to agree to attach his name to a stabilization bed. We couldn't get him to agree to move in, but he agreed to put the room in his name. And we thought, okay, we think this is progress. So we kept doing everything that we were doing, showing up with great frequency. We would have contact with this individual sometimes daily, but most certainly at least 3 to 4 times a week at different times of the day. Always showed up to take him for his injectable medication, which he regularly told us he didn't want to take, and he was only doing it because he knew we were going to show up and ask him to do it. And he eventually, too, moved into a stabilization room. Sometimes he wouldn't stay all the time. He'd go back to his street location, and nobody required him to move his belongings. If he chose to leave them there, that was his property, if that's where he wanted to leave it. But he eventually did start using that stabilization room with greater frequency than he used his encampment on the street. And that was our best effort approach to assuring his safety and continuity of treatment. So, there were other instances where I worked with individuals who were on AOT orders, and each one was different in their own right. And that makes sense because every person is different. But we have to customize our strategies and our approach to engagement with each person as well.
You were really working with the most hardcore population. I mean,
they had a lot going on.
Yeah, they had a lot going on. And just from, my son was untreated and ill for maybe 4 or 5 years. Probably it was a little bit longer than that, but that we were aware of it. And so the things that the delusional beliefs that he had were starting to him to be, in a sense, kind of like such a fact that then he learns about the world and builds his whole worldview around it. And I think the longer something goes untreated, the more that's going to happen. And It's
Well,
going to be
I mean,
much harder to get the
you're
to
never going to engage
back.
somebody by telling somebody, oh, that doesn't make sense, so
Yeah.
you never do that. I mean, that just,
As a mom, I did that, but I can't say it
well,
worked.
and I understand that fully. But I
Yeah.
think for a person like me, I'm coming along and I'm
Right.
trying my best to get somebody engaged in just thinking about, talking to somebody about treatment, just thinking about what they have to say about what that might do for a person.
Mhm.
It does us no good to attack their belief system, and it is
Yeah.
truly their belief system.
Yeah.
Um, but I'm not saying that as a family member, because I know that family
Yeah.
members, and when you live with an individual, that
Yeah.
person
And
feels a
depending what the belief is, some beliefs you can live
yes,
with and other ones you can't.
yes, yes. And also coming from the perspective as the role of a parent, I
Mhm.
think adds a whole twist to the dynamic.
Mhm.
Yeah. And
Yes.
what we did not have in hindsight, we had some recovery specialists, but I do not recall any mental health peer specialists in the state of New York, because I really think that um, there's potential value for people to hear from other people who have had that
Yeah.
experience with the treatment system, to hear, well, how did they sort through that? It may work,
Yeah.
it may not have value, but when I think of, like, whenever us have had any major challenges in life, who do we want to most talk to or hear
Oh,
from?
sure.
We want to hear
Sure.
from the person who's walked
Sure.
that walk before us. And the
Absolutely.
recovery specialists, they were able to come and talk to the folks with serious substance use disorder. And they were just so devoted. They were really such tremendous supports. They were really quite helpful. They made
Now,
a big difference.
did you have any issues with the recovery specialists, or I guess potentially be with peer specialists, that they would not recommend the person to go into treatment? Because I think that's one issue with some of them, is that they will in some cases, tell people that they don't need it when really, they do. Did you run into
I
that?
have,
Not a problem.
over my career, I've worked with a lot of people with lived experience. And I would say, on the whole, I have always respected and valued their opinions. And
Mhm.
so if they see the need for treatment differently than I do, I would want to talk to that person and learn more about that perspective, because who knows?
Well,
That may lead
yeah.
to a better outcome for the person. It may not
For
necessarily be what I was thinking would need to happen, but I'd want to talk to the person.
I'd be interested in talking to somebody, but I guess as a mom, having faced the problem where um my son, do you do you know what happened in my family? We talked a little bit in July when we met, but not a lot, I think.
I do remember, yeah, I do remember brief pieces of
Okay.
it. I do.
Yeah. So we had about a year where he was clearly, definitely sick and in need of treatment. And one of his fixed delusions was that my mother was evil, she was no longer herself, and she had attempted to kill him. And he had a fixed delusion about that. He told everybody about it. It's interesting. I remember the day that that happened. Early in the day, he came into my room and said, "Are you okay?" And I said, "Yes." "Why?" And he said, "I don't know. I just feel like something happened and I'm going around checking to make sure everyone's okay." Okay. By the end of the day, his delusion had filled in content that he had actually jumped up because my mom was trying to kill him. If that was really true, wouldn't he have said that to me when he rushed into my room? But basically, the delusion hadn't filled in the details. And ever after that, he would tell everybody that. And so there really, in our case, there was really only one answer. He needed medication. And I've always wondered if I think if he talked to somebody who had had paranoid schizophrenia, a peer specialist who really was a peer, it would have been okay. And definitely it would have been better to have somebody saying, "Listen, dude, let me tell you what happened to me. Don't go down that road." as he might be able to do someday. But I would be concerned about somebody who was just a peer because they had been inpatient in a hospital once and maybe they have a completely different problem. And the way they solved their problem wouldn't have any value for him, but he would be looking for any possible reason to tell me I'm wrong. And we had that happen. We had a family member who saw it differently from me, and he would always be throwing that in my face. Well, you think you're right about this, but you know, your own relative thinks that I'm right. And basically it became just you know, yeah. So anyway, I guess because I'm a mom and because of my experience, I'm probably a little more closed-minded about the issue. Um,
Well, but I think it's important for all of us, no matter what perspective we represent,
mhm,
um, to take seriously the information that we do know. And in your
mhm,
son's situation, that
mhm.
had to have been terribly frightening for him.
It
Uh,
strangely, he he was just kind of happy and peaceful all the time.
hmm. Because
If
my thought
anybody had
was like contracting for safety, for his safety and everyone else's safety, is something that occurs to me
How would
as
that
sort of
work?
an essential. Well, not really knowing the circumstances,
Mhm.
I would want to involve him in that conversation,
Sure.
because I think when you feel someone in your home and your family that's so close to you wants to kill you,
Hmm.
that's a scary situation, whether he looked like he was scared or not. But
Uh-huh. Yeah.
yeah.
Yeah. Yeah, well, attempts to engage with him on that is kind of like, how can we meet your needs?
Mm-hmm.
Um, didn't really go anywhere because what he thought he was really doing is that in reality, he was helping the angels to crush evil in the world.
Mm-hmm.
They had killed Satan, and there were a couple of other creatures that were evil that they were working on, and that was what he believed was actually going on. And just having an evil person in the house was kind of, anyway, he was hardcore. It was a delusional situation. In his case, um, I think he would have listened to a judge, but I don't think he would have listened to anybody below that. Um,
So your son never got to the point of being considered for AOT?
Well, number one, AOT still doesn't exist and didn't exist back then.
Okay. Mm-hmm.
And the other thing was that he was only inpatient once because he believed that an angel told him to draw a knife across his skin. There was a little thin red line, and they decided that was enough to consider harm. But after that, he got a case manager for Medicaid. And the case manager told him, listen, I'll tell you how not to get in the hospital again, and coached him, which things to avoid doing. And I was unhappy about that. And he was like, well, I don't know, he has a right to know how to stay out of the hospital. In any case, he never again met the danger criteria.
Hmm.
He was just the only time that it was possible we were given advice that it was not possible. Under an AOT structure, it would have been. About 2 months before he killed my mother, he had an occasion where family members were in the house and he was avoiding them. He liked them, they were his friends, but the mental illness, the brain illness is telling him, you have to stay outside, you can't be around them. And he sat outside in the cold for a long time without food. And when he came in, he fell down the stairs. And we called an ambulance and they took him to a trauma unit, just, regular trauma. And I guess his blood sugar level was at 10, which is, near going into a coma, sort of. I don't know much about blood sugar, but it's very, 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 very low. And so basically he had sat outside until he was freezing and starving, and it just killed his coordination. In any case, we under an AOT situation, I think we could have used that evidence to show that he was not able to care for himself, not able to live safely without supervision. Um, but as it was, it the psychiatrist at the regular hospital interviewed him. The nurses were telling me, "Don't take him home. He's off his rocker." And I'm going, "I know." But the psychiatrist said, "Nope, doesn't meet criteria," even though the nurses were.
Mm,
He was
mm,
saying a lot of very crazy things to the nurses.
mm.
Yeah, anyway, we ended up being advised that he could not be hospitalized for that, and because it didn't quite meet
Yeah,
danger
under the
itself.
AOT criteria, you are able to consider the individual's capacity to
Mhm,
voluntarily sustain treatment, which I think is a key consideration for many people that we support. Yeah, I'm very aware that a lot of people in my roles in the various counties um, are concerned, remain concerned after all these years about successfully implementing AOT because
mhm,
it is seen as resource intensive. And I think under certain circumstances, it most certainly could be.
mhm,
But I take my job seriously, and I believe that that's part of my responsibility to continue to do my due diligence to figure out how this can be done and how this can best be done to serve the needs of the
mhm.
residents of my county. It's just part of, it's
Yeah.
just one tool in our toolbox that
Mhm.
we want to figure out how we can do.
Well, I'm certainly hoping Allegheny County does. And in terms of the intensive resources, he's taken a lot of resources since then. So, you know, living in the jail for 4 years and now in state prison cost a lot of money. And
Not at all the outcome. Yeah. That,
yeah, and so it's really um anyway, I wish that we had a framework where I could have used that as evidence to petition for a civil court order instead of, as we were told by everyone, you just have to wait. And when something happens, hope it's not very bad. Well, it was very bad. And that's really not a strategy, but it's what we're left with. One of the things I've noticed is that without there being any particular recourse, it seems like the people who work in the system um, are they don't have any hope themselves. And so when you're the parent or the family member sitting there saying, "Hey, this needs to change or something bad will happen," they've seen this so many times, they're just going, "Yeah, I know." And you say, "What can I do?" And they go, "Nothing, not really anything. Just wait."
well,
Um,
that's most unfortunate when that happens, and I'm not going to
that's
deny that that does
right.
not
I
happen for
feel
some
like
people, but that's
I feel like if they had seen some things where there was something that could be done, they would have a little bit more hope and be able to say, um, "Well, go ahead and give this a try. Seek hospitalization. Document this. Get the records from the trauma unit. Let's put this together and see if we can do a petition." And it wouldn't be quite so much just like, "Oh, well, I don't know."
I mean, under the current statutes, even if the county hasn't implemented AOT, we do have the involuntary treatment option.
But but you have to meet the same criteria for
You do. Yeah,
inpatient, and that comes down to clear and present danger.
you
And
do.
again, what the law imagines is a logical progression from a bit disturbed to more disturbed to making threats to doing little harm, and
But
that's
that's
just not how
why
it works.
our NTAC consultants have advocated that in Pennsylvania, we start with the step down approach. So if somebody's already subject to an involuntary commitment, as part of their discharge planning,
Mhm,
we look at transferring the balance of that involuntary commitment to
mhm,
outpatient treatment. We can do that under the current statute. And a lot of time, the reasons we don't bother with that is because, well, then what do we do once the 90-day order expires?
mhm.
Well, we have a clear choice. We go back to court and we ask for more time, or
Right.
we just let it elapse. But that's conceivably maybe up to 90 days of treatment that the person would not otherwise have had.
Well, that's true. 90 days is probably not enough, though. I know when he did end up at
Probably not.
state hospital, it took a lot longer than that. He put him on medicine
Yeah.
right away, and
Yes.
it was at least 6 months before his view of things began to change even a little bit. So
These are powerful medications, and they do take time for the person to adjust to them. Yeah.
and the thing is, you could stop hearing angels, but you still, the belief system is more like a, um, it's like they've learned that this is what the world is, and now they have to unlearn that and find out, no, that's not the kind of meaning the world has. And that itself takes a long time, even if you can stop the primary thing right away.
Well, and
Um,
sometimes, people just don't give up on that ideology, but the best that can be hoped for is that they won't respond to it. That yes, they know it's always there, and they don't quite understand, in the past why that was such a critical thing. But some people can, with ongoing treatment, at least choose to move on. But
some
it does
people
take
can,
time. It takes much longer
right?
than the period of
So,
inpatient treatment most people
right.
experience.
So the purpose of Pennsylvania, a county opting in on the AOT law would be to have more time to be able to use standards that are not about clear and present danger and that can take in other things like believing he doesn't need to eat or losing his own car and thinking it was stolen when it's right in front of him. Things like that could be counted as evidence, but as things are now for either IOT, the involuntary petition that's possible now, or inpatient, those things aren't dangerous and it just doesn't matter.
Well,
Matter.
so for AOT, the person is unlikely to survive safely in the community without supervision
Mhm,
based upon a clinical determination. They
mhm,
have a history of lack of voluntary adherence to treatment for
mhm,
mental illness within the
mhm,
12 months prior. The person's failure to adhere to treatment has been a significant factor in necessitating involuntary inpatient hospitalization, or they've been involuntarily committed. And within
mhm,
the 48 months prior,
mhm,
the person has failed to adhere to treatment, and that
mhm,
has resulted in one or more acts of seriously violent behavior towards others. So you're allowed to go back 4 years.
mhm.
You don't
But
need to have that recency of
but they're
behavior.
right, but again, they're looking for serious harm, aren't they?
Well, but again, when you can refer to 4 years of behavior,
But he'd never been seriously harmful to anyone in 4 years.
yeah. And that's really, I think, coming from the perspective of not denying rights unless the person has been seriously dangerous to themselves or others. It's consistent with the rest of the Pennsylvania statutes.
Yes, of course it is. And the purpose of the AOT option is to find a way to move past that because I think to somebody who's an administrator or some other official, it sounds very reasonable. But to somebody who's living with somebody, and really never knowing if they're going to wake up in the morning because it might turn, I mean, it should have been me. Statistically, many schizophrenic people come up with a delusion about their mother and they kill their mother, who is the only advocate that they had. There has to be a way not to just keep waiting for danger. And I think to officials who only know about the things that get petitioned, that are dangerous, they're unaware that you get lots and lots and lots of little things where they just don't understand daily life anymore. They, I mean, I would consider losing your car in a parking lot and calling the police to report it stolen and the police come and help you find it. I would consider that a sign of not being able to function in society safely, but it's
Now,
not actively dangerous.
The New York law requires one of two instances, 2 episodes of treatment in a psychiatric inpatient unit
Hmm.
or forensic unit within the last 3 years.
Hmm.
Doesn't even say involuntary. Or one or more acts of seriously violent behavior towards self or others in the last 4 years. So that's
or
interesting. So it's a little bit lesser of a requirement as I read it anyway.
in general, they're also buried in the law, there's usually a phrase about demonstrating a need for treatment, would benefit from treatment, or will predictably deteriorate. And that's where the family can submit these smaller things that the family is very aware of.
Inability to maintain their own needs. Yes,
That's right. And the
that's under
family's
section
keenly
304
aware of
C.
those things. But
Hmm.
as it stands now in Pennsylvania, it doesn't matter. And friends, well-meaning friends used to say to me when I was in that stage and I would be, freaking out about it, they'd say, well, but if you have it in writing that he believes all these things, just take that to a court. The answer is no. But
No,
with AOT,
not a
the
belief
answer might
system,
be
right?
that it would be valid. And so
Yeah.
there's a whole body of evidence that would a family could at least try to bring to bear to get an order telling a person that they have to take medication without waiting for something violent. As in our case, there was only one chance because the first violent thing he ever did succeeded in killing somebody very quickly. And after that, AOT is irrelevant.
Yeah.
And in fact, I'll tell you what's really heartbreaking. When he was sentenced, for various reasons, we were not able to present evidence until sentencing. And at that evidence, with the evidence we presented, we had two autism experts talking about his autism diagnosis and how prison was going to be a bad fit for him, as well as a psychologist who just generally assessed him. And with each one, the judge listened and then said to them, but is there a way to keep him on medicine? And they'd say, well, no. And so when she came to the sentencing, she said, I've heard a lot of things, and I understand that you only did this because you were delusional. I don't care what she said, but you were mentally ill. I understand that. And for the plea that you're pleading to, third degree homicide, she said, I could give you as little as 5 years. But I'll tell you why I'm not going to do that. It's because there's no program to keep you on medication. And therefore, I'm going to sentence you in the standard range, 10 to 20 years, bang of the gavel. And people who have mental illness are not likely to get out. Basically, I didn't understand what 10 to 20 meant until I, was into it. It means that 10 would be acceptable. If you behave well when you're in prison, 10 would be acceptable and we'd let you try again under supervision. But if you can't earn that, you're going to stay till 20. And the problem is because he's autistic, he doesn't like being around crowds. So in the prison he's in, he's at Waymart, and all of the therapeutic programs that they have going on there are for people who can live in a sort of a barrack style. They call it dormitory style. It's more like boot camp beds, you know, 10 guys in one small room as part of a 40 bed large room that they can watch over the whole time. Those are the people who would get to raise a guide dog puppy or, do this or do that. He can't handle that. He got picked on. He asked to go back to something where he could be safe by himself. So they put him in a more restrictive unit where it's right back to a jail cell. And essentially they're saying to him, we've got a library if you want to go to it. We've got a class if you want to take it. We've got these things. But because he's autistic as well as schizophrenic, he doesn't go to those things. He doesn't like being in groups and he's afraid of everything. He doesn't act like he's terrified. He won't tell you he's terrified, but it's very clear that he's terrified of everyone and everything. Anytime I've tried to speak to staff about his opportunities, he will hear about it and he'll come back to me and he'll beg me, never do that again. Don't ever do that again. And once I said, do you think there's going to be some kind of a backlash on you? And he said, no, but don't ever do it again. And the answer is basically yes, he does think that. And he's afraid of the people he's around. He won't go outside. He's afraid to go to the library because if he goes to the library and checks a book out and it turns out there's damage in it, he might get blamed for it, even though he didn't do it because he loves books. He doesn't damage anything. But he's afraid he'll get blamed. And so because of that, in all the years he's been at the state system, since 2017, he has never gone to the library. He doesn't, what else doesn't he do? Oh, and they used to all walk to a mess hall, at least be, being around each other. Since the pandemic, they closed that down. And as far as I can tell, the state prison system has no interest in rolling back any of the pandemic limits. So it's shut down a lot of opportunities for the guys. And basically, my son has spent 11 years he has spent pacing figure eights in his 8x8 cell. That's what he does. He can read a little bit, but the disease is making it harder for him to read. So my little professor that memorized all the facts is now barely able to read because, I'm sorry, I should just stop. The point is, schizophrenia and autism is a really bad thing in prison. It's really bad. They even have an autism unit in his old prison, but because they couldn't keep him on medicine, they had to send him to the one place that basically is a giant AOT order, which is Waymart, the hospital prison. No other place can make you take them. So he's not in the autism unit. He's afraid of it, just everything. He's afraid of parole. He refuses to talk about parole because he's afraid that he'll have to call somebody or else they'll come and get him. And he won't be able to because he'll lose his phone charger. And he has no vision in his mind for anybody helping him because you know why? He's been in the jail and prison for 11 years where he isn't given help. And it's a bad thing. And anyway, I'm sorry, I get talking, but it comes
I'm just
down to
curious, are they able,
he
does
was
he,
sentenced because we don't have AOT.
hmm.
She said because there is no program that could keep him on medicine, he will be there for 20 years.
Well, even AOT, with our AOT law, and this is the same as in New York,
Mm-hmm.
you cannot force medication. So if the person says, no, I don't want to take it, we can't put our hands on the person and require
So
them to take it.
essentially, we can give them a whole lot of moral support and tell the civil court can tell them they have to. But basically, if they just don't still, then what I would like to see is that at least they could be inpatient without again meeting the danger standard.
Well, that's always a possibility through some reform of the Mental Health Procedures Act. But as written now, the criteria are the criteria that would need to be met.
So
Here in
even if
Dauphin
you're on an
County, we
AOT
feel the
order,
best way to initiate an AOT program would really be through step down. Once a person has met that criteria,
right?
to maximize the opportunity for discharge planning to put into place AOT expectations. But that's fully based upon the recognition that if somebody resists taking medication, we can't physically force them to take it. Yeah, that is not provided for in
But you
our
also
statute.
and where that could be okay is if the team could see somebody who's not following the civil court order, not doing anything, unwilling to listen to the team, and if they could hospitalize them for that reason. If they don't even have that, then basically this is a program that would help a certain number of people who just needed to have a team tell them to do it, but not
I
people.
also don't think that refusal to take medication alone
No, but
is,
starting to deteriorate.
look, they have to deteriorate in order to
Right.
meet 302 criteria for the judge to order them back to inpatient treatment. And that's part of our AOT law. Yeah. So, yeah, it's not perfect. It doesn't answer
It'll help
everyone's
some
issue.
people. It will
It,
help
it
some
can help
people.
some people. And
And
that's my personal belief. That'll
and it
help
might
some.
have helped him. And in a sense, it would, I'm kind of stuck on the fact that my son has a 20-year sentence, with the justification that there was no AOT program. That if there had been even that, people would try to keep him on meds, She implied that she would have given him a shorter sentence. And so I'd like to see the program at least there.
So, 11 years, I would guess that there was no ACT team at the time of
We
the
had
incident.
we had mobile crisis teams, we still do,
You did,
that can
okay,
come out and check on whether somebody
okay.
meets criteria. But it
But
has to be dangerous.
ACT is assigned to the individual to work in a continuous basis. Like I was saying, that we went out and we saw people sometimes every day, certainly several times a week. That's what
Yeah,
ACT does.
I
And
don't think
ACT,
we have anything like that in
yeah,
Pittsburgh.
assertive community treatment. They work under
No.
the leadership of a psychiatrist. They
Right.
may have nurses, and
Mhm.
everything is mobile and goes out and works with the person. They're not expecting the person to come to them to
Yeah,
receive their
yeah.
services. They can
So,
work on recreational opportunities with the
mhm.
person as well. So I know in Dauphin County, I don't believe we had ACT services 11 years ago. So that's something new and different.
We might now, I don't know, because it's irrelevant to me now in a bad way. In any case, I guess basically this wouldn't work for everybody, but there's a certain number of people it would work for. Just the persuasion and the team wraparound services, supporting them, reminding them, picking them up and taking to a clinic, whatever like that, that will work for a certain number of people, and we need to be doing it.
Well, and that's my belief. It's just another tool to help reach people who otherwise may not be benefiting from treatment right now. And that's what we should always be about promoting.
That's right. That's
Finding
right.
better creative alternative strategies to help engage people.
Mm-hmm, mm-hmm. Okay, well, thank you very much for sharing your
You're welcome very
experience.
much. And
Yeah,
let's chat again sometime.
okay. All right, great.
All right.
Forward. All
Have a
right,
nice
bye-bye.
evening. Bye.
Good night.